Okay, medicine. Let me just share my screen. All right. So basically, we'll be talking on three topics, focusing on this because of the clinical interface. So you have here your donor selection and processing, which is done by the medical officer. Then you also have your pre-transfusion testing or compatibility testing. It is important for the medical officer to understand the laboratory procedures. And finally, we'll talk about transfusion reaction investigation. Okay. So the blood bag actually contains 450 ml of blood and 3 ml of your anticoagulant. There is a manual entitled Manual on Blood Donor Selection and Counseling, which contains the donor questionnaire, okay, history questionnaire, and A to Z guide. This is being used by the medical officer in FEU NRMF. Okay, basically, a medical officer is a resident or postgraduate intern who must refer to the resident. DOH NVBSE, National Voluntary Blood Services Program, is under the Department of Health. So for the donor history questionnaire, you have here the interview and physical examination, okay, which is conducted by the medical officer after the questionnaire is filled up by the donor. Thereafter, the registered medical technologies will perform the blood screening, that is with regards to the donor's hemoglobin as well as blood type, and then proceed with donation if the patient passes this, the initial screening, and then post-donation counseling and recruitment. So during the interview, be sure that you check the form for completeness as well as identification of the patient. Okay, you check if all the questions are answered and that if the contact information is indicated and the signature is affixed in the form. Be sure also that you check for comprehension. So you reiterate some of the questions, okay, to ensure that they did, okay, read each question. So look at the body language and facial expression of the donor. So here, as you can see here, during the pre-donation interview, this is actually a copy of the actual donor interview form, which is being used at FEU NRMF Medical Center. It is formatted according to the guidelines of the National Voluntary Blood Services Program of the Department of Health. A copy of this form is in the Clinical Pathology course Moodle book. So for the contents of the form, it contains the personal information, the type of donor, personal and medical history, drug history, post-donation activity, AIDS awareness, as well as donor consent. So for the general survey, the questions are like, feeling healthy today? Are you currently taking any medication? Have you received any vaccinations? Or are you currently suffering from any illness, allergy, or infection? It is said that repeat donors are the best, and once deferred, they are usually deferred again. So for the personal and medical history, okay, is being asked, have you taken aspirin within the past 3 days? The answer here should be no. And then if female, you ask if in the past 6 weeks, have you been pregnant or are you pregnant now? You also ask for the date of the last menstrual period. And then you also ask if within the last 12 weeks, if the patient has donated blood or has been deferred as a donor. So here, the answer should be no. In the within the last 12 months, you also ask if the patient had blood transfusion, had surgical operation, dental extraction, had a tattoo or piercing, or engaged in promiscuous sexual activity. Again, the answer to each of these questions should be no. You also ask within the last 12 months if the patient had contact with anyone who has had hepatitis in jail or in prison, or have relatives with Creutzfeldt-Jakob disease. Again, all answers should be no. Moving on, you also ask if the possible donor has lived outside of your place of residence, outside of the Philippines, use needles to take drugs, use clotting factors, or had a positive test for malaria, syphilis, hepatitis, as well as HIV. Again, answer to all of these questions should be no. You also ask if the patient had cancer, lung or heart problems, sexually transmitted disease, hepatitis, malaria, or presence of bleeding disorders. For AIDS awareness, you ask, are you giving blood because you want to be tested for HIV or the AIDS virus? In this question, the answer should be no, okay? Second question, are you aware that if you have the AIDS virus, you can give it to someone else, though you may feel well and have a negative AIDS test? The answer to be given here by the donor should be yes. Oh, sorry for that. And third, were you born in, lived in, or traveled to any African country since 1977? The answer here should be no. So next, you also ask about drug history. So you ask, in the past 4 weeks, have you taken any medications such as Accutane, Proscar, Propecia, Tegison for psoriasis, Feldine, aspirin, or other medications? Have you ever received human pituitary derived growth hormone or taken prohibited drugs? Intake or application of even topical retinoic acid is deferred. Okay. Now, your Tegison is given for psoriasis. For the post-donation activity, you also ask, do you intend to ride or pilot an airplane within the 24 hours? Do you intend to drive a heavy transport vehicle within the next 12 hours? Again, the answer to both questions should be no. After that, the donor should fill up the donor's consent form, which certifies, I quote, I certify that I am a person referred to in the above, and all the entries are read and well and understood by me, that it is my free and voluntary act and deed to donate my blood, aware of the risk and consequences during and after. The same having been explained to me in clear and understandable language and dialect that I speak. So the DHQ shall include an option for confidential unit exclusion if there is any reason that blood donated should not be transfused. Okay. So as an option to self-defer, the DHQ includes Q for donors who are pressured, okay, to donate blood or who are able to recall at-risk behavior or exposure to risk factors during or after blood donation. So give donor the telephone number of the blood bank. When donor calls, give the donor number. So the interviewer must instruct the donor that if he or she remembers there is a risk that his blood is not suitable for transfusion, then he or she must stare the Q part of the DHQ to inform the blood bank. After this, you also check for the mental status, cleanliness, and if the patient is well rested. Okay. The weight should ideally be at least 100 pounds for the donor. The pulse should be between 50 to 100 per minute. Blood pressure should be between 90 to 160 over 60 to 100 millimeters mercury. When you do physical examination, there should be pink palpebral conjunctiva, no cervical lymphadenopathy. Okay, donor should have clear breath sounds, regular rhythm, and no lesions at potential venipuncture sites. So once accepted for donation, the donor proceeds to a donor bed where arm will be cleaned with an antiseptic. A registered medical technologist will use a blood donation kit to draw blood from vein in the arm. So the donation process takes about 10 minutes. For the post-donation instructions, okay, be sure that you tell them not to smoke for at least an hour, to drink more fluids, more than the usual 8 to 10 glasses a day, avoid lifting heavy weights or doing strenuous activities for the next 24 hours, and leave the plaster on for 4 to 12 hours. You also ask the donor to apply pressure for 2 to 5 minutes on the venipuncture site, and in case of recurrence of bleeding, ask the patient to lie down with legs elevated if the donor is feeling dizzy or lightheaded. In the laboratory, after blood has been donated, you do compatibility testing, right? So compatibility testing is not just antibody testing, A or ABO, okay, typing. So in here, you have your pre-transfusion laboratory testing. You identify the patient as well as donor. You do blood typing, cross-matching. You also perform antibody screening as well as antibody identification. For patient or donor identification, it is said that most hemolytic transfusion reactions are due to clerical error. So be sure that you check the labels, okay? There is a unique yet uniform numbering system which is being implemented as it is required. Be sure that there is proper labeling and record keeping. For the ABO blood group system, this is said to be the single most important blood group for selection and transfusion of blood. Major consideration in solid organ and bone marrow transplantation. Cross-matching detects the presence of antibody in patient serum that could destroy transfused red blood cells. It is done by mixing patient serum with donor cells. Okay? Patient serum with donor cells. And cross-matching is done prior to all transfusions of red cell components. You have your whole blood, packed red blood cells, or washed red blood cells. So these are the different phases of your cross-match. You have your IS for immediate spin at 25 degrees centigrade. This detects your IgM. Next phase is at 37 degrees centigrade. This detects your IgG. Third is at 37 degrees centigrade and anti-human globulin. This detects again your IgG. And then you also have your auto control. So here you have the tube method, ABO typing, and cross-match. So only 3 tubes are the actual cross-match. The rest are reaffirming the blood types of donor and recipient. This is the appearance of the gel method for ABO, RH, and cross-matching. And this is the chart for ABO reactions, which we have discussed. For your Coombs antiglobulin test, this can either be direct or indirect. So anti-human globulin or Coombs reagent acts only to amplify the reaction by helping in the formation of bridges. Your direct antiglobulin test detects antibody on the red blood cells and is positive in AIHA, hemolytic transfusion reaction. Indirect, it detects antibody in the serum or plasma. It's also known as antibody screen and is positive in multi-transfused or multiparous female. Okay. So this is an illustration of the difference between your direct and indirect Coombs test. Now, your antibody screen is being done to identify unexpected antibodies. Okay, what are those unexpected antibodies? You have your Duffy, your Kel, your Kid. Okay, what is the clinical significance? It damages IG or protecting IgM. So you want to determine the clinical significance of antibodies that are present. So how do you perform this? You mix the patient's serum with set of reagent blood cells with known antigens. Then you detect the presence of antibodies by direct agglutination or by using anti-human globulin. This is an example of a 3-cell screen worksheet. Okay. You can see here you have your rhesus, scale, Duffy, Kid, Lewis, and so forth, Lutheran antibodies. So this is your antibody screen. You can see, if you recall last week's activity, it is positive when the clot or agglutination is on the surface, near the surface, and it is negative if the clot is below. Okay. For your antibody screen, indirect Coombs or IgA, a positive antibody screen tells us that an unexpected antibody is present and most likely immunoglobulin class. We do not know the unexpected antibody specificity, that is anti-K, anti-D, or whatever. So we have to determine this. Okay, the clinically significant antibodies, you have your A and B, Rhesus, Scale, Kid, Duffy, and S. Most are IgG. So if your patient's antibody screen is positive, you perform an antibody identification panel. So what is the difference between an antibody screen versus antibody identification? For your antibody screen, you use 2 or 3 cell panels. For antibody ID, you at least use at least a 9-cell panel. So this is a sample of an antibody identification. As you can see, you have here on top the different types of antibody. You have your RH, MNS, P, Lewis, Lutheran, Kel, Duffy, Kid. And then you have the phases of your cross-matching, your immediate spin, room temp 37, and anti-human globulin phase. And on the right most column, you see the checked cells. Okay. Usually, if you look at the cross-matching, it is the phase of the anti-human globulin phase which has a reaction. Okay. If you can see, you have your W plus, 2 plus, 0, okay, 1 plus, and so forth. Now, when there is no reaction, if it is 0, then you do the check cells, okay, to check if it is really 0, okay, to confirm it. So here, if you look at it, um, if you look at the different types of antibody, as you can see highlighted in yellow, okay, this actually simulates your anti-human globulin reaction. So when you look closely, it is your Duffy A, which which simulates your anti-human globulin phase. Therefore, this patient or this donor has Duffy A. Okay. So be sure that you do not give the patient Duffy who has Duffy A antibodies the same. So how do you identify the antibody? So first, you look at the last few columns, okay, which I showed you a while ago. You have your immediate spin, room temp, diba? 37, and anti-human globulin phase. Okay. Then you look at the under AHG, you will see that there are different reactions, and then you check, okay, the cells which have 0 or no reaction on your AHG. Okay. Then you match the pattern, okay, which we mentioned earlier, okay, is similar to Duffy A, right? So once the allo antibody is identified, you phenotype donor units or know the frequency of the antigen in the population, and then cross-match until you find a compatible unit. Okay. And finally, we proceed to your transfusion reaction investigation. Basically, your transfusion reaction occurs in the first 10 to 15 minutes or first 50 cc of blood, which is transfused to the patient. Regardless of the type of reaction, it is very important you stop, okay, transfusion, but you maintain the IV line of the patient with NSS. So for mild reactions, you have facial flushings, patient may develop rashes, okay? For severe reactions, patients might become anxious with dyspnea, wheezing, and hypotension. Patients may also develop headache, tachycardia, tachypnea, chills, or if it is the hemolytic type, patients may also develop chest pains, hemoglobinuria, apprehension, and low back pain, okay, as well as increased respiratory rate. So if a hemolytic transfusion reaction is suspected, you inform the blood bank and get a transfusion reaction investigation form. Okay. So you after that, this is paramount because a patient component mismatch implies that an additional patient in the hospital is at risk for the same mismatch and being transfused with the wrong blood. Okay. So post-transfusion receipted blood sample, first and second R, be sure that you get it, as well as urine, and should be obtained and sent to the blood bank along with the blood bank and tubing, okay, for investigation. Now, once you have obtained the blood bag and tubing, you repeat the ABO, the post-transfusion sample of the patient, and the remainder of the transfused unit. Okay, you perform a direct Coombs test or anti-globulin test. You also test the urine for free hemoglobin and urobilinogen. If there is hemolysis, then both are present. You also check the serum for haptoglobulin. Other tests which you may request include serum electrolytes and creatinine to check the kidneys, D-dimer, PT, and PPT, okay, to check for clotting. For non-hemolytic reactions, okay, if you want to investigate them, you request for your complete blood count, gram stain, and culture of the needle, okay, used to transfuse the patient, as well as the tubing, the blood in the bag, as well as the patient's blood. Febrile, okay, hemolytic transfusion reaction is a diagnosis of exclusion. In this case, there is no hemolysis and no organisms on gram stain and culture. Trally, if the patient has evidence of bilateral patchy alveolar infiltrates on chest X-ray with the absence of a circulatory overload and a PO2, FiO2 of less than 300 millimeters mercury. An allergic transfusion reaction, okay, if the patient should be tested for antibodies to IgA and quantitative IgA levels should be assessed. So this is basically manifested as rashes, okay, presence of hives, extreme itching. So this is my last slide. Okay, I will end the session at 5 p.m. Be sure that you answer worksheet number 3 and submit it on Moodle, okay, as soon as you're done, okay, before 11 p.m. tonight. Okay, of course, the earlier the better, so you do not forget. For next week, we'll have again your lab orientation, and then we'll have case 1, presentation, and then discussion. All right? Okay.